Pradnya? आता आहे मला ना आय हॅव टू चेंज आहे ना ओके अगदीच होतात केस तरी नाही. So shall I take it?
Archana, when you want to share screen, कुठला होता ना?
Madam, coming from here.
Okay. काय केलं? असं. When you want to share screen.
कसं? Pradnya? I unmuted myself. प्रज्ञा?
हॅलो मॅडम.
हॅलो हॅलो, कुठे गेली होती? चहा प्यायला?
नाही, हे आम्ही पीपीटी चेक करत आहोत.
अच्छा,
इथेच बसलोय. हे पा, मी आणि गायत्री.
हाय. हॅलो, मी बघू माझं?
हो, आता तुम्हाला को होस्ट करते मी. हा,
बरं.
एक मिनिट. इथे.
का विदाउट दॅट आय कांट शेअर द स्क्रीन?
हा, त्याच्याशिवाय नाही करता येणार ना. मेक को होस्ट करूनच ठेवते तुम्हाला.
बरं. ओके. Okay, can you see the screen? Can you see my?
Fascinating history of women in medicine. Yes.
Correct. आता हे पुढे मागे कसं? मिलिंद? हा, this is not moving ahead with the arrow. Do I have to click it? Just come here for a minute.
मॅडम, त्याला स्लाइड शो मोड मध्ये करा आणि मग एक क्लिक कराल तर पुढे जाईल.
हा, आता मोड कुठे? स्लाइड शो मोड बघते.
राईट साइडला खाली पण आहे पा, अख्खा स्क्रीन दिसतो. हा.
Okay. Now if I click, it will happen. All right, done. Okay, done.
आणि त्याच्यात काही व्हिडिओ वगैरे नाही आहे ना?
नाही.
हा, चालेल.
आता शिवाय एस्केप?
Right? Escape.
नाही, आता हे
Stop share.
स्टॉप सेल कुठे? Okay. All right. Ha, I'm outdated. Will you mind switching the fan on? काय झालं?
नाही,
काम झोप येते मला माहिती. मी रात्री झोपलेच नाहीये. वी हॅड अ पार्टी. तुझी आठवण कोण ऐकते बाई?
मी आणि गायत्रीच बसलोय या खोलीत आणि आमचा अभिषेक आहे, आमचा फेलो.
तर
घरीच आहे.
काल मिलिंद हॅड गिव्हन अ सरप्राईज पार्टी आणि सुरेश वाडकर होता आणि देवकी पंडित, आणि ते आपण ऐकायचो ना, तुला पाहिले मी नदीच्या किनारी. कम्प्लीट ऑर्केस्ट्रा वगैरे होता, ऑडिओ होतं. सो खूप रात्रीपर्यंत चालली.
तुम्ही लोणावळ्यात आहे का की मुंबईत आहे?
मुंबईत आहे. So I am half sleepy. Milind, your tea is getting cold again. You finished it, okay. हा, मॅडम काय झालंय मॅडम ना? कशावरून बरं नाही?
माहिती नाही, म्हणजे फोन कोणाचेच उचलत नाही. हिने पाठवलं तर जुईने कोणाला तरी, तर ती म्हणाली बहुतेक की मॅडम इज नॉट वेल.
कारण असं करत नाहीत त्या कधी. She always answers.
या, आणि मी तर त्यांना मेसेज पाठवला होता फक्त की आम्हाला बोलायचंय. तशी कॉल्ड बॅक आणि सगळं बोललेलं भरपूर. आणि
मी त्यांच्याशी बोलले ना डिसेंबर मध्ये, तेव्हा त्यांना काहीतरी बरं नव्हतं. आय एम ट्राइंग टू रिमेंबर व्हॉट शी सेड. नाउ डेज आय फॉरगेट अ लॉट. पण शी सेड शी इज नॉट टू वेल, असं काहीतरी झालं. So Gayatri, are you a fellow? Are you a resident? Or you
Associate
staff?
Professor.
You look like a tiny girl. Are you from PGI?
No, AIMS New Delhi.
एम्स न्यू दिल्ली. Oh,
नागपूरची आहे आमच्या.
तुमच्या नागपूरची.
Yes.
तुम्ही 2 दगडावर पाय ठेवून असतात, 3 दगडावर पाय ठेवतात तुम्ही, 2 नाही. आई कशी आहे?
आई बरी आहे, म्हातारी झाली. आईच्या नक्षत्राचं लग्न आहे.
अरे वा.
त्याला जाते मी आता 7 फेब्रुवारीला लग्न आहे.
So what's your special interest, Gayatri?
Gayatri.
Yeah.
Onco surgery.
Onco surgery is my special interest. Apart from that, I love general pediatric surgery as well.
But then onco surgery next door, your neighbor is Tata.
Yeah.
I mean, that will be your dream come true if you can get in there. The kind of workload they have is phenomenal.
Yeah, definitely. But here at Vadia also, we are getting a good amount of workload.
I know. I
Given
worked
that
at
we have
Vadia.
got a very supportive hemat-onco department and a BMJ department.
I used to work at Vadia,
Yeah.
so I'm aware.
So the workload is like increasing day by day.
So I think in today's meeting, I'll be the senior most person by age.
Yes.
WhatsApp पे ली तो मैं कोड मुखी ने की दो પછી
નરગીસ તારે સંભળાય છે?
યા સોરી
તું ઘરની વાત અહીંયા કરે ને તો બધું અમને ખબર પડશે. संजय राव पण जॉईन होतोय.
नाही, त्याने हे करून त्याने होस्ट करून लॉग
गेला. पळाला.
कारण IPS चा घेतलाय झूम. तो म्हणाला की हे आपल्या वेबवर रेकॉर्ड होऊन राहील, एनी टाइम वी कॅन वॉच, म्हणून हे केलं.
आता इंडियन पीडियाट्रिक सर्जन्स वरती कोण बोलणार आहे?
विमेन इंडियन पीडियाट्रिक सर्जन्स. आय थॉट मॅडम बोलणार होत्या.
That's what I'm saying. Since she's not there, is anybody replacing her?
भारती मॅडमचा 2-3दा फोन लावला, लागला नाही.
She was in Pune celebrating her brother's 75th birthday.
हो, त्यांना तर ते योगावर आणि रिज्युनेटिंग माइंड्सवर बोला म्हणणार होते. त्यांना पहिले म्हटलं एक्स्ट्रॉफीवर बोला, तर त्या म्हणाल्या की बोलून बोलून सगळ्यांनी ऐकून जाऊन स्वतः झालाय.
घिसा पिटा बोलते ना इसको, घिसा पिटा टॉपिक. That's why I selected this. Actually, I selected this for the Maharashtra State Conference, and it's a very long talk, and I'm not going to talk about all the women, but enough to get everybody interested in history. You know what happens is we forget at times that we are standing on mighty shoulders of somebody else who has done all the spade work and given us everything on our platter. And I think all of us need to pay our tributes and salute these people who have mercilessly, tirelessly worked against the society to obtain what they had to obtain. It's if you read the stories, they're scary. What these ladies had to go through. So nobody's presenting anything from Vadia?
Gayatri is presenting conjoined. आणि डिमांड होती ट्रान्सप्लांट बद्दल, म्हणून मी आमच्या हिपॅटॉलॉजीच्या कन्सल्टंटला सांगितलंय ब्रीफ प्रेझेंटेशन ऑन लिव्हर ट्रान्सप्लांट केस जी झाली ती, आणि त्याच्यावरून इफ यू वॉन्ट टू ओपन अप द डिस्कशन ऑन व्हॉट
you will learn Marathi very fast.
I am Maharashtrian, ma'am.
मराठीत बोल की. मग ठीक आहे, कारण प्रज्ञा स्लिप्स ऑफ इनटू मराठी व्हेरी एव्हर सो ऑफन. तू आमच्या मुंबईची आहेस का? तू आमच्या मुंबईची आहेस?
No, Nagpur.
Born and brought up in
You said you're from Nagpur. Sorry, I forgot. नागपूरला युरोलॉजीचा आहे ना काहीतरी मार्च मध्ये?
Uh,
No,
हा,
no, 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 no,
हा,
no,
हा.
not in March.
नाही,
No, no, that's
कधीतरी
next year. Next
year.
I mean, this year only. Next year.
this next year. Oh, this year in September or something it is.
Yes.
And this year in Lucknow, I want to go there because it's all about bladder, and that is my current topic of interest.
Okay.
Bladder problems.
आमच्याकडे काल उमा अली मॅडम आल्या होत्या. वी कॉल्ड हर बिकॉज वी ऑर्गनाइज ऑर्गन डोनेशन अवेअरनेस वर्कशॉप. मग त्याच्यात चॅलेंजेस इन पिडियाट्रिक ट्रान्सप्लांट वर त्या बोलल्या.
She had invited me for the National Nephro Conference this time. There was a symposium on PULs, long-term results and all. So I just had to review literature and put, but it was interesting. It was a very well organized conference.
Yeah.
Extremely well organized.
मला minimize करू.
Okay.
Minimize करू.
5 मिनिटं आहेत ना?
हो,
अजून?
8 मिनिटं, 7 मिनिटं. मला येला मॅडमचं फोटो दाखवायचं.
तुम्ही कुठून करताय आता हे?
माझ्या घरून.
अच्छा.
आजही लॉग इन हो. बर, पण तिला ठीक आहे. ठीक आहे. हा, नाही काय सांगणार नाही. तिला म्हणा पटकन लॉग आउट होऊन नंतर मी तिला पोस्ट करून ठेवते. लॉग इन झाली तर मी तिला पोस्ट करून ठेवते, म्हणजे मग वेळ नको.
अभिषेक.
हा, म्हणजे मग तिला पोस्ट बनवून ठेवते.
How do I insert this?
अरे अभिषेक रेड्डी कोण आहे? I thought this was women's conference.
ಇದು ರೂಮ್ ಗುಡಿಸ್ತೀರಾ? ಆಯ್ತು ಆಯ್ತು ಆಯ್ತು. ಅಲ್ಲಲ್ಲ ಮಾಡ್ತಿರೋದು ಮಾಡಿ ಅಂತ ನಾನು.
Hello.
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 Hello. How are you?
Fine. It's
Good to
nice.
see your dot on time.
Yeah.
I'm
I like
just,
to be on time.
yeah, that's right. I'm just getting into Delhi. I was traveling out, but I said, let's join in right away.
Hi Pradnya. Happy birthday, madam. Kirtane madam, happy birthday.
We had
Kiss the
muted myself.
birthday
Thank
heart.
you.
Manju.
Happy birthday from me also, ma'am.
Thank you, Shalika. Thank you very much.
See you
You're
after
using
some-
your daughter's. You're using your daughter's
Yeah.
laptop.
Yeah, that's my
Oh.
only achievement in life.
You mean
Oh,
the daughter?
I am also using Adar's laptop.
Jyotsna, happy
So
birthday
sweet
to
to
you.
see you,
Thank
ma'am.
you. Thank you very much, Meera.
Change. Cake cutting.
So it is 4:30. Where's Pradnya? Pradnya was here.
लाईट चांगला नाहीये.
कोणाच्यासाठी माझा?
नाही ओव्हरऑलच असं वाटतंय.
सुरू करूया मॅडम 4:30.
Yeah.
Only 22 participants. थांबायचंय थोडस की विल स्टार्ट.
Nine. We will start.
Okay.
We should learn to be punctual.
Yeah.
I agree with Kirtane, ma'am.
Yeah.
Hi, Usha.
Hi, ma'am. Happy birthday.
Thank you.
Birthday.
Any madam is joining? Nine.
याच्यानंतर
Hello, Kirtani madam.
Hello.
Very happy birthday. Dr. Natasha here.
Thank you. Where are you now? Oh, yes. I can see you now. Thank you.
Hi.
Yes. Hi.
Hello, madam. Sarita.
Hi, Sarita. Where are you? I'm not used to all this, so
Very happy returns.
can't
Very
find
happy returns
Sarita.
of the day, madam.
Thank you, Sarita.
Have a great year.
Thanks. Nargesh, reveal yourself, yeah?
People know me.
But it's nice to look at faces instead of just names.
Yes.
Hello, Nargis, ma'am.
Hi.
It's such a nice. I'm feeling so good about everyone to see everyone.
Yeah, seeing you after a long time.
Ashlesha, hello.
Hi, ma'am.
How
Hello,
are
ma'am.
you?
Kirtane, ma'am. Happy birthday. I'm good, ma'am.
Thank you, Ashlesha.
Thank you so much, ma'am.
Happy birthday, ma'am.
Happy birthday, ma'am. Thank you. It's done. Huh? Now, no more happy birthdays. Let's get on with the meeting.
म्यूट कुठे अनम्यूट कर. Yeah, good afternoon, everyone. So for the people who were not there in SpookOn, let me just give you a quick background how we thought of starting this group. So while we were having lunch in SpookOn after multiple presentations, which were very nice by lady pediatric surgeons, we realized that presence of women in whole session was pretty inconspicuous, hardly 2 or 3 presentation, and there we thought that we need to have our independent platform where we start presenting and eventually hopefully dominate the field. That is how this Wonder Women WhatsApp group was formed, and
Nitya, you have to help me.
objectives of the group, why we want to do this. So one request is everyone can put down what the objective of this group should be. They should think about their goals and objective, and they can put in the chat box, and at the end of meeting we will just go through and frame structured objectives of the group. Then quickly going to today is very special day. So I can't start program without wishing our beloved madam, Dr. Kirtane madam. Happy birthday to you.
Who's singing? Make it quick, Pradnya. We don't want to stall on this. That's okay. I received all the good wishes. Let's get on. Thank you. Thank you, everyone. That's very pretty. Thank you.
Madam, how old?
How old? 76 old.
How young?
76 years young.
Any age.
Very nice.
I have a word to say, Pradnya, on what you said in the introduction.
Yeah.
I don't think we are here to prove our dominance in the field of pediatric surgery, because work speaks for itself. So men are also doing good work, and we are not going to run them down or anything like that. But women are coming up and they need to be encouraged. So let's think positive. It's not about shadowing anybody, but about getting into prominence by putting out good work and good results. Okay.
Next slide.
So, Pradnya, let's start, I think.
Yeah. So let us start by introduction of women pediatric surgeon of Maharashtra. So the first pioneer pediatric surgeon of Maharashtra and probably of the country, Dr. Snehalata Deshmukh. She has been teacher for all of us. Very strong, charismatic woman who must have taken lots of challenges to start the specialty. Today, actually, she was supposed to give a blessings talk for us, but because her health is not keeping well, she won't be attending and giving us the talk. But when I talk with her on phone, two things I distinctly remember about her. One thing she always used to tell in all the talks: disabilities, deformities, defects, why to despair? Haven't got sent pediatric surgeon to repair. So I always keep that in mind. And so there is no limit for our work. And as my madam said, we will do well in every field. Second thing, she said that she was one of the first few female presidents of IPS. And after that, none of the females have become president of IPS, to best of my knowledge and to best of her knowledge also. And she said people very proudly introduced in ASICON this year that she is the only female president of ASI and IPS. But she said, I don't feel proud to hear this. I want someone else also to become president of pediatric surgery. So let us keep that in mind and let's move to the next pediatric surgeon. While Wadia Hospital is hosting the function, I cannot start the function without giving tribute to my beloved madam, Ila Maheshwari. She was known for many innovative procedures. Very confident. She has been role model for many pediatric surgeons. So Dr. Ila Maheshwari. Kirtane madam is here and she is going to give us address. Another mother figure for me, teacher figure for me. So Dr. Jyotsna Kirtane. Bharti madam always had a holistic approach, not looking only at the physical defects, but emotional, mental needs of human being. and hopefully she is there. If she is not there, we'll hear her in next CME, and we must hear from her how one can keep mind at a poised pace. So yoga and rejuvenating minds is her specialty, besides special pediatric surgery and extrophy bladder. Dr. Nargis Barsiwala, all of you know, one of the senior pioneer pediatric surgeons in the city of Mumbai. Dr. Padma Karve, I couldn't get her CV, but I'm pretty sure she is very keen to Josna Madam, Bharti Madam, and one of the senior pediatric surgeons in the Maharashtra. Manisha Albal, again, we are not able to contact her, but she was one of the good pediatric surgeons practicing in Vidarbha from the beginning when there were not many pediatric surgeons in that area. Anjali Chitale, very, very methodical surgeon. Her handwriting, I still remember after several years, Motya Sarkha Akshar that we call. She is in Nasik, heading the department. Sarita Bhagwat, as second generation of pediatric surgeons started, Sarita is one of the senior most among us. Sarita is there in SRCC hospital. She was in Vadia for several years. Reconstructive surgery, I would say rather intricate surgery is domain for Sarita. Jyotsna Kulkarni, one of the pediatric surgeons of our batch who has been practicing in periphery. Majority of the surgeons that time settled in Mumbai, but a few of them who has gone in periphery and started good practice is Jyotsna Kulkarni, which is in Nashik. Then it's me. Sushmita Bhatnagar, everyone knows her, very dynamic pediatric surgeon. Right now she is practicing in Bombay Hospital and many other hospitals. Besides pediatric surgery, she was president of Association of Medical Consultants. Legal areas is, I think, her special interest besides surgical oncology and all. Sunita Aroe and Kamath, she was trained in Birmingham Children, after trained in Vadia Hospital. She is practicing Thana onwards in periphery of Mumbai. Himanshi Shah, head of the department of Nair Hospital, must be teacher of many students. Nair is one of the topmost ranked pediatric surgical center in Maharashtra. First toppers go to Nair. Bijal Sangvi is professor of pediatric surgery in SETGS Medical College and KEM Hospital, Mumbai. Manjusha doesn't need introduction. She is omnipresent in pediatric surgery. Shalika is a professor of pediatric surgery right now in Sion Hospital. Then Meenakshi Bhosle, another dynamic personality who is out of Mumbai. So she was in Pune, switching between Pune and Mumbai, but very well known for her work in child abuse and sexual abuse. Received multiple awards like Lok Satta Durga Award. Usha Gajbie, current, I think, secretary of Maharashtra chapter of pediatric surgery. One of the very dynamic pediatric surgeons from young pediatric surgeons. Zui is known, I think, to everyone. Again, another omnipresent like Manju. Nandita Saxena, seen occasionally but becomes very popular. She was there in Spokane for some time and then she was everywhere in Spokane. Everyone was calling, where is Nandita, Nandita, Nandita. Flavia D'Souza Thakur, my most favorite student. Very dynamic. And I'm pretty sure she is going to achieve special sublime heights in field of pediatric surgery. Ashlesha, again, very proud that she is again from Vadia Hospital and doing very good work in Pune. Monica Bhagat, one of the few pediatric surgeons who like to specialize in subspecialty. Her special interest is oncosurgery. Gayatri Mungate is here. She is associate professor at Vadia Hospital. and she will be doing lot of things, and she is going to be the main surgeon in pediatric transplant program. Shama Kulkarni is a very popular pediatric surgeon in Pune area. Hemangi Athavale is assistant professor in JJ Group of Hospital, one of the pediatric surgeon who is dedicating in teaching institutes. Shishira Shetty is a pediatric surgeon who practices in periphery of Mumbai. Natasha Vagheria, I think she is already here, is a very dynamic pediatric surgeon. Right now is a full-time pediatric surgeon and developing department in Hiranandani Hospital. Pooja, along with Natasha, is working with Bharti Madam in DY Patil Nehru, and they are doing excellent work, and they have developed Center of Excellence for Extrophy. Ashwini Khanolkar is doing a lot of laparoscopic work and is the honorary consultant pediatric surgeon in KJ Somaiya Medical College and Hospital and SRCC Hospital. Abhilasha Handu is again consultant pediatric surgeon practicing, and Paritosha Thakur is also, these are few young ladies we were not able to get details. Then Deepa Peswani is working in KEM Hospital. Neha Sisodia is colleague for Himanshi at Nair. She's associate professor there. Again doing good work in minimal access. Geeta Kekre is practicing in Pune. Rujita Shaha is assistant professor in KEM Hospital, Mumbai. Aboli is pediatric surgery lecturer in Sion Hospital. Apurva Makkan, I think she sent her biodata just last moment, which we couldn't add. She is gold medalist in pediatric surgery. She's from Nair Hospital. Dhvani Shaha, very, very pleasant personality in pediatric surgery. She has done MCH from Sion. And Jaini Modi is another dynamic lady. She is right now working with us in Vadia. Akriti is in Gujarat, again doing very good work. And I think here introduction of the pediatric surgeon, women surgeon in Maharashtra staff. We have total 42 pediatric surgeons in Maharashtra who are doing excellent work. Many are doing excellent work in the subspecialties. After the introduction, may I request Kirtane Madam to take over for her address for us. Madam, please.
Yes. Thank you very much. Am I visible? Okay. Am I audible and visible?
Yes. Yes.
All right. Good evening, everybody. It gives me great pleasure to be part of this new world of brave women pediatric surgeons across India. And I hope this is not the first and the last meeting, and that it will catch on and with better and better ideas and more development. Well, I'm not going to talk on any surgical topic today. It's about women, fascinating history of women in medicine, not pediatric surgery. We'll see. Let's see what happens. I'm trying to share screen now. Can everyone see the screen? Hello?
Not yet, madam, not yet.
No? You can't see?
No.
Okay. Well,
share screen, madam.
I've done share screen. One sec. Share screen. Now?
No.
Milin? Sorry, I need help from my spouse. Milin, come. This share screen is not working. Share screen. See, I'm clicking on share screen here. Can you see now?
No.
No.
And they made you a co-host.
Yeah, I'm a co-host. I'm a co-host, right?
Yes, ma'am. You are co-host.
आपलं stop sharing केलं का?
हो, आपलं stop sharing.
या option.
I'm not able to share screen.
सर परत बघा मी मल्टिपल पार्टिसिपंट कॅन शेअर स्क्रीन केलं ऍक्च्युली
Multiple participants can share. Okay. So when I click share screen, now?
No, sir.
No?
No.
Close everything, sir, and again restart. I mean restart the procedure.
Rejoin?
Probably.
that also you can do.
So what picture are you seeing in my window now?
Same, like we are.
तर आम्ही तुम्हालाच बघतोय.
Acha, you are not. Okay.
No.
Okay, I'm going to close it and start again.
Yeah.
Why don't you ask him to mail it to you and then you can share it?
मॅडम तुमचं आता झालं होतं started screen sharing.
I had started when we checked before the meeting, but now it's not coming.
Yeah, now it is coming.
I can see. We can see your computer now.
Okay.
So yes. We can see your computer.
So
Desktop.
If you start PowerPoint now, it should work.
No, but
Yeah. We can see your. Correct. We can see now, sir.
Okay.
Full screen. Yeah.
Yeah, we can see.
Thank you. Thanks. Okay, sorry about the delay. So I'm going to take you on a tour of fascinating history of women in medicine. Very few of us are aware of what all. You can hear me, right?
Yeah, we can hear you, ma'am.
Okay. And see the screen. Yeah. Okay. So very few of us really know about history of women in medicine. We are too busy doing our own stuff. So I came across this book of lady doctors, The Untold Stories of India's First Women in Medicine, which also tells about world's first women. This is by Kavita Rao, and it's a fascinating book. I would recommend this book for everyone, not only women, but also men. And this is what inspired me to give this talk. So who are these women we're talking about? Everyone knows about Anandibai Joshi, but how many of us know about the rest? Kadambini Ganguly, Rukma Bai, Haimati Bati Sen, and so many more. Somehow or the other, none of these women, their names appear in history or textbooks. They're just forgotten by the male-dominating society, swept under the carpet. But these are the very women who have inspired a lot of other girls or ladies to take up medicine. Now, let's start with a very, very fascinating, unbelievable story of Dr. James Barry in the mid-19th century. Now, this is a man, surely, but he was born as a girl, Margaret Ann Bulkley, born in Ireland in 18th century. And unfortunately, after her father died, her father was really a doting father. After he died, a paternal uncle came and molested her. That's what the story says. And of course, she got pregnant and she was whisked away by her mother to some other place. And when she came back, she was dressed as a man. So as a boy, rather, with cut hair, dressed as, in attire of a man. And from that time onwards, she became Barry, James Barry. James Barry was her maternal uncle with whom she stayed. And this Mr. James Barry had very high connections. And he is the one who really prodded her and encouraged her to get into medicine. And pretending to be a man, Barry tricked not only University of Edinburgh, the British Army, and the Royal College of Surgeons. So it's the longest deceptions in the gender identity ever recorded. He was also a military surgeon. So henceforth, I'm going to refer to her as him because her entire life, she masqueraded as James Barry. So when she qualified, actually, she was not getting admission. He was rather not getting admission because he didn't have any facial hair. So the administrative people said that, well, you're not old enough, so you cannot enter this medical school. So that is when her mama, her uncle, who was original James Barry, his help really mattered a lot, and he contacted some influential people in the government, and that's how she got it. Even those days, these things happened. So that's how James Barry got admitted to the hospital. Of course, she was ridiculed and teased because she never got facial hair, right? And squeaky voice was another thing she could not change. But despite that, this James Barry persevered and determined to become a surgeon. He did become a surgeon. And then he was posted with the British Army. So wherever there were colonies, British colonies. The first one posting was in Cape Town, South Africa, where he worked for almost 14 to 15 years. And that is where he did his first successful cesarean. Up till then, either the mother or the child would die. But this was the first case where both lived, and that's what shot him into fame. And then by and by, he was appointed, when he was posted in Canada, he was appointed to the highest post in Army, that was the Inspector General of Hospitals. And he practiced for long 56 years. Now, at the time of his death, see, so nobody knew except his very close people that his sex was not really the true sex that he revealed. So at the time of his death, he had requested to be buried in the same clothes that he wore without being examined or inspected. But that did not happen. And that's what started a big discussion about his sex life and whether he was a DST, whether he was a transvestite, or was it only because she wanted to become a doctor and that was the only way she could enter a medical school and become a surgeon. So hats off to her, having masqueraded for such a long time, not an easy task. And this inspired another woman, Dr. Elizabeth Blackwell, again a Britisher. She did her studies in medicine in the United States. So she was recognized by the Lancet as the first woman medical graduate in the US. Now her family was a large family, very affluent family in UK, dealing with sugar factories and all. But they migrated, the whole entire family migrated to United States. And there the father actually became a pauper because of whatever reason. And he died, leaving behind only something like $20. And it was a large family of 7 sisters and 3 brothers. And the sisters had to start working. They started teaching. Now, it so happened that one of Elizabeth's friends was dying of cancer. And she went to meet her. And this friend said, Elizabeth, you must get into medicine because the plight of women is terrible. They don't like to reveal their private parts to male doctors. And there are only male doctors around. So this is the need of the hour, need of the day. And you have to start applying and get into medicine. So this is what inspired her to get into medicine. She tried to write for admission. She was rejected by 29 medical schools and finally accepted by 30th. Why? Because they thought it was a joke. They never seriously considered it till they saw that she landed at their doorstep, bag and baggage, to be admitted to their med school, and then they had to get her in. So she attended Geneva Med School in upstate New York in 1847. Those days, the med course was only 2 years. So she graduated 2 years later, but she could not practice in the US. Nobody would go to her. When she went back to UK, there, of course, a lot of praises were heaped on her. There were a lot of parties thrown in her honor. But when she thought about practicing there, no way. Nobody wanted to go to a woman doctor. And that is the time she thought that she should go to France, to Paris, because Paris was a little more advanced. She thought then, but she was delegated to only the maternity wing. Unfortunately, while working in Paris, she lost one eye to infection. And therefore, her dreams of furthering her career and becoming a surgeon, her dream was shattered. So she went back to London the next year, where she met Florence Nightingale, who initially was her friend, but in her books and her comments, she has despised every single woman who tried to go into medicine. So she went back to New York. She was again unsuccessful. Just imagine, after having struggled so much, gone from place to place, what does she get? No success, only failure. So then a bright idea struck her, and she started a lecture series for health and hygiene of the adolescent and also of the children. these are the days there was no sense of hygiene at all. I mean, surgeons would wear the same bloody gown all the time without washing it. They would not scrub. The theaters were dirty. It was really filthy. They were stinking. And Elizabeth Blackwell was the one who really strove hard for public health. She was a crusader for public health. In the meantime, she traveled back and forth across the Atlantic to get more and more women into medicine. In 1859, first woman doctor was registered in medical registry. So she was the first woman doctor who was accepted in British medical registry. She then went into setting up women's colleges, and first one she set up was in New York. And this is what inspired many more followers. And in 1974, she joined the London School of Medicine as a teacher of hygiene. And this was started by none other than Sophia Jex Blakewell, who happened to be her student earlier. And of course, Sophia was not alone in starting the School of Medicine. She was joined by other ladies as well. Now, her namesake, another Elizabeth, she started nursing for 6 months because, she couldn't, there was no way there was a lot of resistance in getting ladies into medical schools. And she started thinking in a roundabout way. She thought she would do nursing first and then get into medicine, but she was kicked out by male students. So what she did, a very smart thing, apothecary was accessible to everybody. So she did apothecary, which gave her license to practice. And she got her name enrolled in medical register. So that was something very important, a landmark. But when the male society realized that a woman has been enrolled, they changed their rules. So no name was added for the next 12 years. Again, the same story repeats here. She opened a dispensary in London. Nobody came. But as luck would have it, there was a massive outbreak of cholera. And male doctors were flooded with patients more than they could handle. And all this overflow flocked to Elizabeth. So that year, she treated over 3,000 patients. And then, because she wanted a medical degree, she was not happy with apothecary. So she learned French, got medical degree from Sorbonne. And that was France's first ever medical degree for a woman. So she was a strong advocate of women's right to both work and have a family. Now, a lot of us are doing that. We have a family and we work as well, but she was one of the first pioneers of that. And she went back to UK, and her old dispensary was renamed as New Hospital for Women and Children. And her real success or triumph came in 1876 when UK Medical Act allowed universities to admit women. Now, these are the famous 7 Edinburghs. The 7 girls joined Edinburgh Medical School. They were callously denied their degree despite completing their course and passing their examination with honors. And 150 years later, just imagine, that is when University of Edinburgh woke up to this cruel act of theirs and acknowledged it so much on a plaque which they put up in their university, commending their courage of these 7 women in overcoming bigotry and discrimination. So that brings us to the Indian scenario. In 1865, this brave girl was born, Anandibai Joshi. As was the tradition then, she got married off at the age of 9, but to a husband who was 17 years older to her, and he was a widower. Now, I don't know whether to call it a blessing or a whatever, but because he was passionate about women's education, but at the same time, he was very cruel and ruthless. He would beat her up with a wooden stick. He would not let her cook, which she ought to have done according to the customs those days. He just wanted her to study all the time. But this did not dissuade her from studies. Any other woman would have been dissuaded with all this beating. It was the stick and carrot attitude, more of a stick and less of the carrot. But she was sent to Mumbai by her husband to study in a missionary school. Missionary school were those days governed, and the teachers were all from UK. So she picked up English very quickly and she became extremely fluent in the language. She also became very independent, and she did things which were unheard of at that time. Now, it so happened that Gopal Joshi was working with post office in Pune. they used to get tribunals and newspapers from abroad, and he learned that in UK and USA, women have started becoming doctors. So this got his attention, and he said, hook by crook, I have to make Anandi a doctor. Now that was easier said than done because the finances were not possible. So he wrote to Dr. Royal Wilder. He was an American missionary working in India. There were quite a few missionaries who did a lot of good work. And he asked for help, financial help, and Wilder immediately offered to help, provided the Joshis converted to Christianity. Now that was their aim. This, of course, they refused to do. But what happened? Just look at the serendipity of the whole situation. That this news, they used to have something like a newsletter. So all this was published in that newsletter. And 2 years later, another American missionary called Theodosia Carpenter, she happened to read this. And she got so interested and she felt for this girl, Anandi. And this started a stream of letters between Anandi and Aunt Carpenter, as Anandi called her. And they really became very good friends. And she was so good in English, and her thoughts at such an immature age were also so mature that Lady Carpenter was really impressed. And this is what culminated in Anandi's resolve to travel to US alone. Now just imagine a little girl of 18 planning to travel across the seas, across the 7 seas, so to say, to a foreign land. And she was met with tremendous opposition. The entire society rose up in arms against her. The newspapers started talking gibberish about her, saying that, oh, she's going to be converted, she will wear Christian dresses, and she will eat beef and whatnot, and she would not be accepted back, etc., etc. So there was such a furor over this matter that her husband, Gopal Joshi, decided to call a meeting. Now, by this time, he had transferred himself to Calcutta, which was the capital then. And he thought that the chances for Anandi to go abroad was much better in Calcutta. So this scenario is in Calcutta. So he organized a meeting in a place called Serampore, a huge hall which was packed with people, Indians and Europeans, in the college hall. And Anandi decided to face them all, not Gopal Joshi. She told her husband, I am going to face them. And she was barely 18. This is her first public meeting, and she's addressing a motley crowd. And she literally, point by point, she answered each and every question with such strong determination that people were really impressed. As a matter of fact, this all got printed and circulated, and she got tremendous public support. So that finally she sailed from Calcutta on 7th April 1883. Now, I'm not going to go into the details. She met with a lot of hardships. The climate, the weather was terrible because she was in Philadelphia and she had to wear 9-yard sari. But defeating all this, she graduated in 1886. But she was ailing. Actually, when she left for US itself, she was ailing, and it got worse with the bad weather. And of course, poor diet, because she could barely get anything vegetarian. And she came back after her graduation, but she felt so sick that she could never practice. She died soon after she came back to India. She had probably contacted Cox. Now let's come to this Bengali person, Kadambini Ganguly. She was actually born in Bihar, not in Bengal. And she was the first graduate. She did her Bachelor of Arts in 1882. And she got married to her teacher, who was an excellent person, a proponent of women's education. She entered medical college because by then things have started opening up, because whatever happened abroad in US and UK reflected in India. So the college was open, she could get admission, but there was such a spite against women. And she must have been the only one in that class as a lady. So in the final exam, she was failed by 1 mark. They couldn't fail her by more marks because it must have been really tough. And this was out of spite. But even then, she got a degree. But instead of getting Bachelor of Medicine or the MB degree, she was awarded Graduate of Bengal Medical College, but she was allowed to practice. At that time, the Dufferin movement was taking place. And there were a lot of funds made available. Hospitals opened up under the name of banner of Dufferin or Lady Dufferin Women's Hospital. to encourage women to get into medicine. But who took advantage of this? Not the Indian women, but the British women, like the Edinburgh 7 who were not given any registration in UK. They landed up taking different jobs in these Lady Dufferin Women's Hospitals. And these ladies were paid much, much higher salary. And our Kadambini was paid a meager salary. But she was the first woman doctor to practice in India, which is very, very important. Anandibai could have done this, but ill health prevented her from doing it. But Kadambini could practice. Now, she was not getting patients. So look at this lady. In 1888, she put up advertisement in newspapers to get patients, saying that she'll treat poor patients free of cost and she'll have very moderate fees, etc., etc. But she was still not getting any patients. She got so frustrated that she thought that only a chappa of foreign returned with a degree from Edinburgh would help her. So she did that. So she left her children in her sister's care and left for Edinburgh, only for a short period, because she had already studied all the courses and she just took some examinations. And she then was awarded 3 lovely diplomas of Royal College of Physicians, Surgeons, etc. And then she was appointed back home as superintendent of the hospital. And at the same time, she started private practice. And she was the first woman with a flourishing practice and 8 children to take care of. But this great woman has also faded into obscurity. Now we come to a Mumbai woman, Rukmabai Raut. She was born in Mumbai to a very rich father, but she lost her father at the age of 2 years. Now she belonged to a so-called low caste of those days. She belonged to Sutar family. And there, her mother being a widow, in this particular caste, she was allowed to remarry. And her mother married Dr. Sakharam Arjun, who was teaching at Grant Medical College in the subject of botany and Ayurvedic drugs, etc. But Sakharam, in spite of being his father, he was a visionary. And he encouraged Rukmabai to study a lot, but she got married off at the age of 11 years. And when she attained puberty, Sakharam sent her to her husband's house. Now, Sakharam, sorry?
तो आप में से दोनों में से कोई एक अंदर रह सकता है.
What happened?
Decide कर लो.
Hello, can you please, the other people, can you mute because I don't understand what's happening. So, luckily for Rukmabai, her father mingled with big reformers, Indian and Europeans, and she learned a lot in these meetings. Besides English, she got good thoughts and good ideas. She was a rebel and a fighter. And she wasted 4 years fighting for divorce from her husband. But she was so restless, she wanted to become a doctor somehow or the other, and she was wasting her life fighting divorce cases. So finally, she paid up 2,000 rupees to her husband, got her divorce, and immediately after that left for UK to study medicine. And Dr. Edith Pechi, who was then working at Kama Hospital in Mumbai, helped her. She was one of these Edinburgh 7. So she helped her finance her trip to UK. And just look at her, the luck she had. In London, she was lodging with McLaurens, who were very progressive and wealthy couple. And this completely transformed her world. It introduced her to several intellectual people, including Alfred Lord Tennyson. She got admission to London School of Medicine for Women. She worked very hard and she became very popular with teachers and colleagues. Can you imagine, she even met Prince of Wales during this time and made friends with Alice Russell, who was wife of Bertrand Russell. So she was really rubbing shoulders with very highly educated and cultured people in society. And that made her confidence grew and doubled almost. And then she got a licentiate of the Royal College of Physicians and Surgeons and was entered into the British Medical Register. She returned to India and joined Madame Kama Hospital. At that time, she got an offer from Gujarat, Surat, and she picked it up and she worked in that hospital for 22 long years, where she encouraged women to come to the hospital for delivery, because those days they were having home deliveries. And then she did a lot of social work. She started women's group under the guise of reading religious books. And she quietly taught them to read, write, sew, and a lot of other things. And this group grew from strength to strength. So she did a lot of good work getting women, educating women, inspiring them to do better things. And then she got herself she moved to Rajkot to practice further. She was very popular with the rich and royals, although she worked for the poor most of the time. But she was doctor to the Rani of Palitana, and she was introduced to the famous Ranji Trophy player, Ranjit Singh Ji, who was a royalty. So she did not have to suffer hardships like Kadambini. And after retirement, she lived in Mumbai and published a pamphlet called Parda, the Need for Abolition. In those days, and we are still fighting for this. And her end came when she was 90. I think, Pradnya, there are many more stories, but this is enough to encourage everybody and to see what kind of hardships and what kind of life and determination these brave women had. And I really salute them. There's a long list, but you'll find all that in the book I talked about. So I recommend very strongly all of you to read this. Thank you.
Okay, madam. Thank you. Actually, there was some time, but that's okay. It was very, very inspirational. And we know we already are having a ready-made platter, and we can do much more and advance in subspecialties and leave mark in the history. So we move on to next case. Jui, you are ready?
Yes, madam, but you will have to make me host.
Yeah, I have already made you co-host.
No.
Okay. So move on to next case, a complex case managed very nicely with excellent outcome by Dr. Zoe Mante. Zoe, all yours.
Madam, you'll have to make me host. Acha, I have made already. Okay.
She made you host. You're a co-host now.
You can start, Joey.
Yeah. Can you see my screen?
No, no, not yet.
Okay.
We all are waiting.
Now can you see?
No.
Not yet. We can see you and the light in the theater.
Zoe, parat हे कर मगा सबको join and हे करून टाक.
Okay, okay.
I had the same problem.
Stop
I
and
think there is some problem in the Zoom link, Pradnya.
you'll have to stop and rejoin, I suppose, same like Keertane ma'am.
Sir was there, now doing the OT, so there is no one to help her.
No, let me just see what.
कोई प्रॉब्लम है क्या?
You can leave and join again.
Need someone more tech savvy than you.
Okay, I'll just get someone.
Happy Republic Day to everyone.
Manju.
काहीतरी ते Alt S press कर. ALT S. डेस्कटॉप याच्या कीबोर्ड वरचं.
गेली ती. एक लोहेकाची केस आहे प्रज्ञा.
हा तू फोटो पाठवला.
I have to be able to share screen. So what is happening is
Share screen.
Alt S press कर ना.
Phone a friend.
Oh, no, friend is there.
Many friends are there.
Yeah.
Else you can just email your presentation, somebody else can share.
तू ते कीबोर्ड वरचा Alt S प्रेस कर ना. Alt S.
Alt S.
Alt S.
Unmute करा मी.
Alt and S. Just try it, Joy.
Alt S, if you can see desktop and application then.
And then when you share it, play it like it is on your.
दुसरं प्रेझेंटेशन घेऊ का मॅडम मग मी तोवर?
नाही करू दे ना तिला. करेल 2 मिनिट. This is the online problems, different problems.
Yeah.
Shilpa was saying that Saroj Chudamani madam and Shanti Talwar madam was
President.
And before that, Dr. Mirabai was there.
Yeah.
Achha, there are 4 president from IAPS.
President handful. Hello.
Julie, meanwhile, I think you can email your presentation to somebody and they can share.
Okay, I'll do that. That will be easier. Who shall I email it to?
To
Pradnya.
Okay. Because many newer generation is more tech savvy than our.
Don't say that. Shalaka, you are still a newer generation.
No, I mean younger than me. I think Pranya ma'am is the best option. Pranya ma'am must be having the
younger than you.
Resident doctors along with them who
Achha.
are more IT savvy.
Pranya madam's daughter?
Madam, Suhas Pradnya at Yahoo, na?
Ho.
Hello, Dr. Lakshmi.
Hello, hi.
Hi.
It's an amazing meeting. I mean, first of all, the introduction.
Lakshmi, meanwhile, if you want to say something, maybe you can.
Yes, I would love to. I'd love to address everybody. Yeah. I think on the sidelines of the SPUCon, when we were all meeting and having lunch, that is when the idea of this, establishing a group for for women pediatric surgeons really came up. Because I found that, yes, we go to a lot of conferences and we do meet socially. But how many of us women are actually coming to the forefront and being accepted on an equal basis as presenters and as, somebody who's called upon to show operations? Yes, a few of us women have made it. But considering the number of women pediatric surgeons that are there today, and for example, you were talking about so many of you in the Mumbai area. I'm sorry to say that I didn't know so many of them before. I mean, the top names, yes, they are famous all over the country, but really we need to reach out and encourage each other in this fashion. So I'm very, very happy that this is born fruition, and we are here in this meeting today, getting to know about each other. And I hope that we move from strength to strength in this. The first step is actually to make the bonds. And that's what we want to do. We want to know about each other. I mean, someone was asking me, okay, so you want to draw up a list of women surgeons who are going to demonstrate surgery? Tell me who's good in what surgery. And frankly, I don't know. I don't know in the 4 corners of India, which of the women surgeons are good in which surgery. And that's what we need to know. And I really want that all of us should contribute to our forum in various different ways. I mean, be it about encouraging to like Manjusha, to talk about your physical achievements. I would like some women to come and share about how they've managed a family and workplace, because that is a very important part of our life. I would like some people to, demonstrate to us their surgeries as recorded videos, So it's not just one person. I would like all of us to put ourselves out there so that we can reach to each other and we can form links. That is the whole purpose of this.
Shall I say something here?
Yes.
At the recent Maharashtra State Conference, there was a suggestion that a lot of rural surgeons who are not into laparoscopy and who are doing open surgery, they need to watch videos of open surgery, you know, the standard procedures. And if you open YouTube, you find that most of it is lab or robotics. You rarely now find open surgery demonstrations. So why not we ladies take the initiative, prepare nice videos, not too long, maybe edited videos, and compile and then send it to the person, whosoever, Dr. Rasik is handling it or whosoever is handling it. Regardless, I don't think there's a bias against women. I really don't think so, because I think I'm the second generation of pediatric surgeons, and we worked hard at JJ Hospital, and our papers, every conference we presented a lot of papers and they were applauded. I mean, I got a lot of satisfaction.
Ma'am, I'm not saying there is a bias against women surgeons. What I'm saying is, because of our various commitments with family, with everything else, we are happy to play second fiddle. We are happy to sit in the audience and watch. I'm just saying, you look at the numbers and they speak for themselves. I'm not saying that we are not presenting, but we are not presenting enough.
Yes,
I'd like to
but
change
the mindset, Lakshmi, the mindset differs from person to person.
Yes.
You know, there are some who are more ambitious. Others would rather do just their little job and enjoy family life more. And you know, where you have, like, I was so lucky, my parents looked after my children. So I wasn't really just leaving my children with my servant to take care. So if you have, see the advantages of joint family.
Yeah,
No,
no,
it's true. I
totally.
mean, I have come forward only because my children have now grown up and they've left home to go and join college. So, you know, I am free. So I'm at this point at time, I'm saying, okay, let me do something more, and let me do something more for my sex, for my, my category of people who have various commitments, various commitments. Yes.
I think totally agree with that. But Lakshmi, your point is well taken, that the proportion of women who are taking and the proportion of women in the lead, that is disproportionate.
Yes.
Correct. We don't disagree there. But like Jyotsna, I was lucky. I had parents to look after the children, and I could, be just free to do what I wanted to pursue.
Right.
Thank you.
So how far is Zui come with, or Pradnya come with a presentation, Zui's presentation?
I've sent it on WhatsApp also.
Yeah, that's what I heard, but.
Or we could do the next talk.
Why didn't you do the next one? Yeah.
Yeah, I think so.
You can send to me also meanwhile. I'm able to see the screen.
Do you have Shilpa's email ID?
Yeah, Pradnya started.
Oh, yes.
Okay.
Yeah.
Okay, so please, madam, can you do full screen? Pradnya, madam?
See it? I have done it full screen. Can you see the screen?
Yes, yes.
Zui,
She wants it full screen.
Open the presentation now.
Openच आहे.
नाही म्हणजे फक्त आता presentation दिसतंय. We can see your desktop now. Now the presentation is getting open. Now make it a full screen.
Click enable editing, only then you'll be able to make it. It's a protected view.
Okay, anyway, I will start talking. So recently we had this patient in the NICU. Next slide, please.
Click on slide.
Not going to the next slide.
Gayatri, click on the next slide. On here in the sidebar, left sidebar.
Yeah, so it's a 4-day-old male baby born in a different center. Birth weight was 1.8 kgs. feeds could not be established there. So the patient was shifted to our hospital in the NICU. There was a distended abdomen, bilious vomiting. They had presumed it to be NEC and shifted to us for management. Next slide, please. So, as expected on examination, baby was dehydrated, premature. There was respiratory distress. There was a right upper patch. There was abdominal distension, dark green bile in the infant feeding tube. Loops were seen in the upper abdomen. It was fairly sure that this was something to do with the intestines. CBC showed a hemoglobin of 13 gram. Platelets were 90,000. ABG showed metabolic acidosis with a bicarb of 12. Serum creat was 0.9. All the other investigations were normal. There were no associated conditions. Next slide, please. This was the X-ray. So the one on the left is the X-ray which was done outside, day 3 of birth, which showed all the gas in the upper abdomen, no gas in the lower abdomen. And when they came to us, this was the 4th day X-ray, which showed 2-3 gas shadows in the upper abdomen. So assuming that this is a atresia, we explored the baby. Next slide, please. So this was a jejunal atresia around 18 centimeter from the DJ. Next slide, please. But there were multiple atresias. So when we went traced the bowel loop, there were 15 atresias. So initially I could only see 4, but then when we started flushing the intestine, it wouldn't go ahead. So there were 15 atresias. Next slide, please. This is a pictorial depiction of how they were. So 16 centimeter from DJ, there was one. Then there were septae, like a type 1 in 3 in the next segment. Then there was an 11 centimeter segment with 2 septations. So like that, there were around 15. So I wondered at this point that with 15 atresias, what should be done? I had thought of just telling the relatives that nothing much can be done. Then I thought that maybe we can try to join as much intestine that we can, because the whole colon was available. There was no atresia in the colon. So I decided to salvage whatever was possible. Next slide, please. So I did 9 anastomosis. So this was done with 6-0 Vicryl interrupted, and patiently it took quite some time, but we finished 9 anastomosis and saw that everything is passing distally. Also thought of putting a tube across, but then it was a 1.8 kg baby and I thought that it may perforate somewhere. So we didn't do anything. We spoke to the relatives and said that it looks difficult. But we had quite a good result with this. Next slide, please. So on the post-op day 2, there was little gas distally. Post-op day 3, little more. Post-op 9, it was like absolutely normal. Next slide, please. So feeds were started on post-op day 5. Full feeds were reached on the 10th post-op day, and he was discharged on the 13th post-op day. This was miraculous for me because I had never thought that after doing so many anastomosis in the intestine, this child is going to do well. Next slide, please. So baby is now 2.5 years on follow-up. Was admitted at 1 year of age with adhesive obstruction, which we treated conservatively. After that, I had 2 patients. There was a patient with which we had to do 4 anastomosis in a child with NEC. He developed a short gut syndrome. He is now 2 years of age but has failure to thrive. So weight is 7 kg. Then another child 1 year back operated 3 anastomosis, multiple atresias. There were 6 atresias. He has dysmotility with enterocolitis on and off, but his weight is good for age. So next slide, please. So I really this case changed my outlook, is that we should never give up on any sort of anomaly and try our best, because it just may work out. Whatever we do, it just may work out. You don't have to give up on things. In literature, there were so there are generally very less cases in literature also. So there is this hereditary multiple intestinal atresia. This was a case of two siblings to non-consanguineous parents with pyloric atresia, multiple small bowel and colonic atresia, and severe immune dysfunction. So this is a syndromic sort of a thing, and both the babies succumbed. There's another case report which is preserving bowel length with a transluminal stent. So we were thinking of putting a stent. So some people have put it. In 8 patients, stent was externalized. That was brought out of the abdominal wall at the end. And 3 required reoperation for stricture or leak post this. There's another report in literature about how we can improve perinatal case in isolated multiple intestinal atresia. So in 30 years, they had 7 patients. So they have suggested 3 techniques, that is multiple resection anastomosis, which we did, Santuli's technique with resection anastomosis, and anastomosis over a tube. So all of these patients survived. Only 2 patients had like a small bowel syndrome. So generally, it looks like this is something that would work well if it is an isolated multiple intestinal atresia. Next slide, please. Thank you very much.
Excellent
Very nice,
work,
very
Zoe.
nice.
Any comments? Excellent work, Zoe.
Yeah,
Thank
excellent.
you.
Really, yes.
Yeah. Yes.
So
Joey,
how many
how
of
long did it take you, Joey?
it took me 2.5 hours.
That was really fast.
Very fast, yeah. It's very fast.
Yeah.
Generally, first it took half an hour to wonder what to do. And then the rest, once we had made up our mind that we are going to anastomose, then it became
Anything different you have done?
Just
putting a stent, putting a feeding tube, feeding
No,
jejunostomy.
we actually thought of putting shunt tubing across.
Yeah.
So my assistant in this case was Dr. Pradeep Shenoy, and we thought that we will put a stent across. But since he was 1.8 kgs, I thought that the chances of that stent perforating would be a little high. And also I thought that generally I don't put transanastomotic tubes. So I thought that while pulling, if it gets stuck there, then we can't do anything about it.
So, Joey, one more suggestion. I saw that you had like 16 centimeters from DJ and about 16, 17 to the ileocecal junction. I mean, in this case, you were very fast and obviously you had a very good anesthetist with a 1.8 kg. And if you had reduced the anastomosis to maybe 2 or 3 and sacrificed maybe a little bit of the atretic segments, which were only 3 and 4 centimeters in some of them. Here it was lucky. Maybe you could have had some places a prolonged anesthesia. I mean, I would have taken longer, would have been faster.
No, so in all the segments were not long enough. So where there were atresia at smaller distances, those were discarded. There was 15 atresias. We did 9 anastomosis.
Right.
So it was discarded. We could not anastomose everything because there are some places that are 2 centimeter or 3 centimeter. So that had to be discarded. So we first started out discarding whichever ones that we could not, that were too short. And then we started anastomosing and realized that, okay, this is coming to 9, but the intestine seemed healthy. So we left it at that.
Very nicely done, Jui. How was
Very nice.
How was the mesentery? Was it normal?
The mesentery was very normal.
I think that was the plus point in this.
Yeah. So there was no gaps in the mesentery. It was just like a type 1, type 2 sort of a thing.
Nice.
On follow-up, Zui, any malnutrition you are giving any supplements?
No, we did not give supplements because the baby was feeding well, but he did get admitted after 1 year with intestinal obstruction. But that was probably adhesive obstruction, which we could manage conservatively. Now, then after that, he has not got admitted again, and he's on regular follow-up. So vaccinations and everything. So the height and weight for age is within the percentile. So there's not much of a problem.
And you had chance to explore one more time. So there were any signs of adaptation, dilatation, or anything?
No, we did not explore. We
Okay. Okay.
Zoe, you were talking about some case reports of hereditary or multiple cases. So we had one at Jaslope when quite a few years back. It was again a very premature baby and came from somewhere in South India. There was a history of previous two siblings having died from similar problems. And they had actually adopted a child, and this one had a apple peel syndrome. And miserable looking thing, 1.5 kg. We operated, of course, and the child lived, but again, not thriving well at all.
So I wonder, because apple peel, I think, has a universally bad prognosis, but the mesentery doesn't do very well, and children come back with. So we did one apple peel and joined it to the adrenal anastomosis, but the child did not do. He died after a year with malnutrition, and we had to operate twice after that for adhesive obstruction.
Juhi, can I ask a question, Dr. Prema?
Yes, madam.
Yeah, did you straighten the DJ flexure? That was one question. And usually it's the bulbous first part, the duodenum and jejunum, the very first, the one just proximal to the first atresia, which takes maximum time to settle down, I think. That is one question. I think in your diagram, you have shown some webs also, because that is one association we have also seen where some are, you can obviously see that there is an atresia like type 3 or 2, and then it is associated with webs also. So I think you've shown that in the diagram, but I'm interested to know about the DJ flexure straightening.
So since the first atresia was 16 centimeter from the DJ, we did not touch
the far away. Yeah.
It was quite far away, so we did not have to straighten it at all.
I've seen some which are very close, and then you feel that better to straighten that.
Initially, we were tempted to bring that, like a duo sanctuaries, bring out the proximal jejunum and then keep the distal things. But also, I think that a 1.8 kg with a very high jejunostomy doesn't do very well.
Yes.
So these were called the proximal chimney and distal chimney surgery described by Santuni, but I don't think anybody practices these nowadays.
No, they do. In a report in 2022 for multiple atresias, they have done this.
I see.
With fairly good results. But I think babies have gone home with TPN and everything. So I don't think in our setup yet it is feasible to do that.
That's right. I think you got away without this Santuli, so you have done a good job.
It was luck, I think.
No, don't. That doesn't take the credit away from you. Not luck. This was hard work. And
did you do any investigations for immune deficiencies in this child?
Yes. Whole panel was sent. A genetic workup was also done, but there was nothing. But usually the children with this syndrome have pyloric atresia also. So the essential part of it is pyloric atresia with SCID.
No, I also had a child with just multiple intestinal atresias with an immune deficiency. And I think the essential part of it is a hereditary multiple intestinal atresia. So more than anything else, there will be some other history of deaths in the family or other problems in the family. So, but it's always safer to investigate all of these.
Yeah. So we did a genetic workup as well as sent the whole panel for immunodeficiency. So that came clean. And this child did not really behave, like was not in sepsis, started feeding on day 5.
Excellent.
So there was not really much to suspect.
So that is amazing, Zoe. Feeding on day 5 with so much handling of gut. That is, you've really done a very good job.
Believe me, out of the whole NICU and everybody, I was the most surprised because I had explained to the parents that it probably will not survive, and we have just tried a last ditch effort. But the most surprised person was me.
Besides your hard work, looks like you prayed a lot.
Definitely, I pray every day for a lot of things.
Superb job, Zui.
Thank you,
Multiple atrezias, multiple question. I think still few are unanswered, but can we move on to next case? Dr. Gayatri is going to present the next case. Gayatri, please.
Yeah, thank you, ma'am. And I'll be presenting these cases. Actually, these are very complex and rare cases, the cases of conjoined twins. So this was the first set of twins, the ischiopagus, the female twins joined from the level of the umbilicus below. From the photographs, it is, if we are seeing, it is not clear whether the limbs on one side belong to one baby or both the babies. And they had an opening, anal opening on one opening on each side of this thing. Here we can see some amount of meconium has been passed. So a CT scan was done, which shows a doubtful dural sharing. Here again, multiple imaging was done to ascertain the organ sharing, the spine, the shape of the pubis, the union, etc. And the surgery was done. The first surgery that was done was the colostomy in each baby. This shows a common channel. There was a long common channel with an opening at each end, and a colostomy was done. There was a single bladder through which a suprapubic catheter was passed. So this was a dye study showing a common bladder and the dye from the individual stoma going into a common channel. The 3D reconstruction of the CT scans. So this again was done to ascertain whether there was any fusion of the vertebra and the dural sharing. So there was some doubtful dural sharing, pelvic floor, and not much musculature in the pelvic floor. So cystogenitoscopy was done and implant was inserted to expand. And this particular slide shows the vessel which is common to both the twins, the sharing vessel. So there was the common bladder, 2 double vagina, grossly deficient pelvic floor. There was some dural sac sharing, wide pubic diastasis. The skin was deficient. The reconstruction was done. 2 bladders were reconstructed from one common bladder, vagina and aneurysm separated, keeping one for both babies. The abdomen was closed with peritoneum. There was no muscle or skin. It was covered with collagen. And this is how the postoperative it looked like. So right now they are like both the babies have grown up 8 or 9 years. They are going to school. They have a stoma, each individual. Yeah. And I'm sure most of you have seen the video of both of them dancing. This again was a second set of ischiopagus twins. It looks like the babies are lying over each other, but no, they were joined from the level of umbilicus down to the scrotum. It looked like they had a single scrotum with 2 testes and 1 penis. On closer examination, we could see 2 meatrices, indicating that there are 2 urethra. So a lot of again, as usual, a lot of planning, the CT, the 3D reconstruction, looking at the this skeletal and the this thing from all the other angles that was done. This again, CT shows the common vessel that is shared by both the babies and is a cause of much concern. So these this set of twins were separated. This was a very, very complex surgery. Before the surgery, the point of changing the gender of one of the twins was also discussed with the parents, since it appeared that there are only 2 testes. But after the lot of imaging, it was revealed that the 2 sets of twins had 4 testes, 2 scrotal, 2 abdominal, and 1 phallus. So the phallus reconstruction and everything was done in a very skillful manner by Madam. This was the third set of twins. This was relatively easier, but not so easy because this was a Omphalophagus, Thoraco-Omphalophagus sharing liver. And there was again a vessel which was going across the twins. So these twins were also successfully separated by Madam. This is the intro picture, which shows that we were able to go extraperitoneally. The peritoneum was not opened. We could find a plane between the individual this thing, and the common vessel was ligated. And this is the postoperative picture. So in total, 3 set of twins had been done by Madam. The 2 of them very, very complex cases. And the first set was done by Madam in
Ila
Maisheri Madam, with Madam assisting the Madam. So this is like this is the present picture of the 2 of the twins, the Ichthyopagus twins, and this was the first which was done by the Madam in the residency. So all of them are like very happily separated. This was possible because of the great teamwork that we had. The entire teamwork, we had a lot of mock drills, lot of discussions, and lot of planning, and every person had put in their best to make this a success. And with this, I'll conclude this presentation saying that these are like very, very rare, very, very complex cases. And I would not hesitate in saying that Madam has the maximum experience of conjoined twins. Thank you.
Not Madam, I think Narayana has maximum experience of conjoined twins. But maybe in Wonder Woman, probably I'm fortunate enough to get these cases. To mention about these cases, these were very intricate as it is expected. We had multiple discussion. I think Kirtane Madam was there in discussion for all the cases. She was even there in OT. So all the senior surgeons in the city of Mumbai were there to guide us. This second twin was with us since antenatal period, diagnosed antenatally. We tried to avoid surgery. So the goals in conjoint separation were first delay the surgery as much as possible. That would give us a chance to study their anatomy as well as try some tissue expansion because deficiency is expected. And then every study can be done. In spite of CT scan, we have done MRIs, angiographies. We need to find out how much blood they are sharing, through which organs they are sharing, how much organs can be separated. So the goal becomes cosmetically, functionally, socially acceptable to individuals. First goal is that. In Ischio and Omphaloziphy Ichthyopagus twins, the first 2 twins, it was possible to delay the surgery. It was complex, but it was possible. In first and last twin, one which was done by Ila Madam and the last one which we have done, it was a liver which was sharing. And in general, the observation was wherever the liver is sharing, if gallbladders are seen separately, separation is feasible. Sacrifice is not required. But when liver is sharing, there is too much of twin-twin transfusion. So in both the cases, it happened. So one child was over-perfused, another child was under-perfused. One child also showed the signs of early congestive failure, though we didn't wait for frank failure to develop, and we separated before that. So liver sharing forced us to go in early. So when the first twin, which was done by Ila Madam, that child was hardly 3 or 4 days old. The last conjoined who was sharing liver was couple of weeks old. That we tried to postpone the surgery because child was very much in the hospital, and by the time we got this twin, the NICU department is very well established. And this couple of days, we tried to separate the twins by keeping a bolster under the bridge, applying olive oil and all those things, and extended the bridge so that skin cover can be done. But yes, there was one vessel going from one liver to other liver, and in all the conjoint, there was a plane of separation. So one need to understand that Plane of separation is generally maintained. Two peritoneal leaves we have to separate, and that can serve as a good covering. So for the Riddhi Siddhi famous conjoined twins adopted by the hospital, they had a huge defect, 11 inches and 9 inches, and whole bottom, including the bowel, was covered only by the peritoneum and then the collagen tissue. If any questions are there, we'll be happy to answer. Otherwise, we move on to next case. This is very, very intricate, so I don't think we can present fully in this meeting, but we'll go to the next case.
Very nice presentation, ma'am, on conjoined twins.
Yeah, excellent work. Did the collagen take up well? Did it get epithelialized later?
Giving such good results is commendable.
Shivangi is presenting last case, that is going to be the last case, and we are presenting this case because there were many queries in the group about how we started the transplant program. So this is just to initiate the discussion on how every pediatric surgery can start the transplant program, especially the teaching institutes and public hospitals. They should be starting transplant program. There is too much of disproportion between the demand of organs and number of transplants done in pediatric patients. Not even 100 of children are getting justice. So we can save many more children if we have a transplant program. Shivangi, please go ahead. Shivangi is junior consultant in Department of Hepatology and Gastroenterology, and very, very dynamic. She has put lots of efforts while doing this transplant. Shivangi, please take over.
Am I visible?
You are, yeah.
Yeah. Good evening, all. Thank you, Pradya ma'am, for the wonderful introduction. So I'm Dr. Shivangi, and I've been working with Vadia for past 2.5 years. And it was a pleasure for me to join Vadia in the first ever transplant, and which turned out to be a successful story. So we have a patient who was a full-term normal vaginally delivered male patient presented in the first week of life with jaundice. He did not require any NICU admission and was treated on OPD basis with multiple LFTs, which is suggestive cholestasis improvement of age. Then there was a loss of follow-up for the patient and presented to the cardia at 2 years of life with jaundice, occasional itching, inability to walk, and pallor. There was no history of bleeding from any side. Liver biopsy was suggestive of giants and hepatitis. A genetic workup was sent, which was suggestive of ABCB11 mutation, which favors P62. For 6 months, patient did well on the conservative management, but after that, patient started decompensating in form of coagulopathy and ascites. Patient also had multiple episodes of sepsis owing to his immunocompromised status. He also had sustained a pathological fracture of right femur. Initially, mother was identified as potential donor, but due to uncontrolled diabetes, father became the donor. After identification and donor workup, we were able to go ahead with liver transplant on 16th of October 2022. Surgery was uneventful, but due to existing poor immunity and requirement to balance the further immunosuppression, we were able to extubate after 10 days with a total of 36 days of hospital admission. We discharged the child with 11.5 kgs weight. The patient was readmitted in November after discharge within 2 days with complaint of fever. We did a liver biopsy which showed acute cellular rejection, grade 2. Pulse steroid therapy was given, and within 2 days child was discharged. Currently, child is post-op to 3.5 months, 3.5 months, and he is doing well, active, is playful, and able to walk without support, and has gained 2 kilos since transplant, and is 13.5 kgs now. These are his serials lab. So initially when he presented to us, he had anemia, he had coagulopathy, jaundice, and the synthetic functions were deranged. Post-transplant, we can see the child has picked up well, and after treatment of the acute cellular rejection, the latest labs, we are able to control his LFTs quite well. So this is the kid who's pre-transplant. His bilirubin touched as high as 24, and over the right side you can see the kid. He is now all fine, walking and happy. Thank you. Over to Pradnya ma'am.
So the only message here that we want to give by presenting this case was there are very few teaching departments and public hospitals in India who are offering transplant, and there are less than handful of pediatric surgeons who are involved in transplant. We are losing many areas in pediatric surgery to other specialities. There is too much of overlap between the urology, plastic surgery, and this is one important areas where dedication and exclusive practice probably is required, and it should be the part of pediatric surgery, and it should be subspecialty of the pediatric surgery. Like ever since we have started doing transplant, though we have, our numbers have not increased so far. Every week we get references, at least 1 or 2 references of children who need liver transplant. There are many areas where we need to work, like finances, infrastructure, and team training. But yes, everything is doable in our department. Our own team is involved in this. They are doing training and they are able to manage with the high volume work of Padia Hospital, as well as get themselves trained in transplant. So yes, but few mentors are required. For us, liver transplant program is mentored by Dr. Dara S. Mirza, who has graduated from KEM Hospital, but after MS surgery, he was in Birmingham Children's Hospital, and he's a dedicated transplant surgeon who is encouraging pediatric transplants in India. And for kidney transplant also, it is adult urology team. My own colleague, Dr. Sujata, is helping us. So after a short, when we look at the technique of surgery, it is not impossible for us to learn that technique. We are already doing hepatectomy. We are already doing complex liver tumors. So it is just a coordination of team that is required. As far as finances are concerned for kidney transplant, most of the government institutes will get the finance from government schemes. And besides that, not much funding is required. Post-operative immunosuppression, also there are multiple government schemes which provide immunosuppression. So if you look at the logistics of all the transplants, everything is doable. There are many indications. I would say that our outlook of biliary atresia will completely change once we adapt transplant services in our hospital. But yes, besides surgical team, good medical counterparts, that is nephrologist for kidney and hepatologist for liver transplant, and good intensive team is needed. Our nephrology team, our hepatology team, our intensive care team also had no experience, but in one case we learned quite a lot. But for that one case, almost for 1 month, everyone was there in the hospital. Till late night, several nights we have spent in the hospital. Several days and nights before transplant surgery, we have studied, rehearsed, worked on it. So short period of complete dedication, yes, is required. Second limiting factor is equipment, which probably is not difficult to get in government hospital, especially in centers like Shilpa Center, AIMS and all. So CUSA and Harmonic and Cell Saver, except few things, everything else is available in most of the centers. So logistics wise, everyone I think has that. Besides that, it comes to the getting licensing of the institute. What we have done in our institute is almost for a year or so, whole of our team was visiting transplant center. We were going to Apollo Hospital to see liver transplant and to KEM Hospital to see the renal transplant. At least for our state, only 10 to 20 cases you get participated and then you get licensing. And once you are licensed, then you can at least start assisting or doing part of the transplant. Transplant is not one surgeon's job. All 3-4 surgeons are equally important. Donor surgeon is important, bench surgery surgeon is also important, and recipient surgeon is important, and one person cannot do all these things. So you have to divide the surgery in phases, giving equal importance to the surgeon because every job is interlinked. And besides that, I don't think much is required. We started many organ donation awareness program. Yesterday only we had a workshop on that, and what we realized is when there is a need of 1 million, hardly 1,000 people get transplant. And when you motivate 200 patients, you hardly get 5 organ donors. So this disproportion will be bridged only when every institute in India and every pediatric surgeon gets involved in transplant and consider it as a part of our privileges and part of our job. If any questions are there, we will be happy to take, but this was just to stimulate thought process in everyone's mind, because we are not seeing transplants in pediatric surgery programs in any of the institutes.
Yeah, very good, Pratnya. This is really good because I think the cost in the private is still prohibitive.
Yeah.
And so if we can offer it in public hospitals, I think it's a big service that you're doing. So all the best to you, and many other centers can take it up. I think that's encouraging.
It is definitely very encouraging. You are doing so many things: urology, transplant, hepatic, laparoscopy, so many different things. And I hear now robotic surgery is coming to Wadia.
Don't forget conjoined twins.
Conjoined.
Zoe, you come to Wadia and Robo will come. Thank you so much. I think with that, can we conclude the meeting? I don't see any questions in chat box, but the last thing that was remaining was to decide objectives of this group. So if anyone wants to give any suggestions, or anyone want to give any suggestion on how this group should be, whether it has to be a formal group, whether this can be a formal chapter of IAPS women's section, and then we can decide on objectives. If right now no one has any suggestion, maybe we can continue the discussion on the group, but there were a few questions about what are the objectives of this group. And our activities should not stop. So maybe in this week only, let us decide who is going to take next meeting and how they want to do. It can be like guest lecture, it can be video presentation or whatever. Shilpa, any suggestion? Dr. Meera, any suggestion? Madam?
Good evening. This is Pavai here from South India. Can you hear me?
Yes.
Hi. It was a great meeting. Great idea. Good job. And actually, I think many of you may know that there's a women pediatric surgeons group even in the US. They call it the Benji group. So, and what they actually look into is they have these kind of Zoom meetings. They have physical meetings also. In addition, they look into the specific problems we as women surgeons face. And for example, just as a small example, we go for a conference, we bring our children. Who looks after the children? What happens? So there's kind of small things for the youngsters. So
yeah, so there's always a spouse program which is aimed at women, never at men. So, so I think, that's what we need to do. The spouse program has to cater to children and spouses, whether they are men or women. And I think instead of making it very formal, we should keep our discussion to where we have both men and women, and try and focus on places where we can encourage the newer pediatric surgeons to come and join the fraternity and give them an opportunity to, join the mainstream. It's like I feel very happy if I'm able to even persuade 1 out of 10 candidates to go and do pediatric surgery if they work. So I think that's the way we want to work, encourage our own, but necessarily don't break it up into pediatric surgery men and women.
Yeah, I agree.
I just wanted to say that what we are talking about here, in the UK also, as Pavi was mentioning, there is an actual forum called Women in Surgery. Okay. And they have a different agenda. It's not about we trying to say that we have been shunned by the men or we are different from that. We're going to run parallel meetings. No, it's not like that. But women do have other commitments, which makes it difficult for them to run a career and work simultaneously. And a lot of these, and as I was saying that before, that if you actually go to the Royal College website, they also run separate programs which are based for the women who are trying to get into the career. I mean, most of us who are talking here are all already established. We've all been there. We've done our hard work. We've struggled in life, and then we've come to a certain level of comfort. And I think it's very important for us to reach out to the younger surgeons behind us, and I would really hope that we can establish some kind of mentorship for the younger surgeons who will be, the younger women who are entering into surgery or in their early phases of career, and who would be able to, talk to us, and we could be a support for them.
Can I say something? Hi. So, what is what is our objective? Basically, do we want to make it official or let it remain informal for the encouragement and support to each other? I think the second one is better. We don't want to make it official because there are so many groups already in the IAPS.
True.
So
maybe we can ask Sanjay Rao sir also what he thinks about us. He's there.
He's there?
He's not there apparently.
Sanjay, are you there? He must be there. I can call him.
So instead of making it formal and this thing, then all this politics, basically the election, all the president,
I totally agree with her.
we don't want that.
I
We
don't
just
think
want
we
to
need that.
encourage and support each other. We want to just maybe discuss the new ideas, like Pradnya has now stimulated the thoughts of transplant and everything. So we should be like monthly meeting. Everyone should be meeting monthly on this online platform. That is the best thing, I think. And in between, WhatsApp discussion will go on.
Manjusha,
I
let it
agree
be
with
informal now.
Yes.
Let it be informal now. And for example, now the West Zone people we've got to know, maybe the next the East Zone, and finish everything. Let's get to know each other first.
Correct.
And then we'll take it up. Let's not form a separate forum now. That's not the idea at all.
Yes.
That is not the idea.
Yeah.
And maybe, if possible, when we are having an IAPS meeting or when we are having some other regional conference, we girls could just plan something on the sidelines of that. Maybe outing, where we could socialize.
Yeah.
That's
You just took the words out of my mouth. I was
Yeah.
thinking on the same lines.
So that would
And
be really nice. I would like to get to know all these wonderful women outside of an academic forum also,
Correct.
It'll be lovely.
That's right.
I must thank Pragya for such a fantastically organized meeting.
Yes. Yeah.
It's such great structure. It was absolutely fabulous. And I wonder if there are any takers for the next meeting. I mean, Shilpa, you want to do something at the north side?
Let's decide the date on the group and then.
Yeah, I mean, I can always take up something for the south zone, but I think, maybe north can do next and then we can.
Clockwise.
Yeah.
No, that's okay. We can do it from the north. That should not be. We'll try and fix up a date which is suitable, except the next month. Maybe what we'll do is meet up in Pondicherry and follow it up after that, after Pondicherry. Because a lot of us will meet up in Pondicherry maybe we'll have just an unofficial meeting up in Pondicherry, whoever is there, and then chase it up to see what we can do further. Does that sound something good?
Yeah.
It sounds great. Sounds great.
Okay.
I think
So
Dr.
we'll set
Sanjay
aside.
is here again. Sanjay, are you there?
Yes, I am here.
Yes, Sanjay is tuning up.
Sanjay, you're quietly listening on to us. Eh?
No, I wasn't quietly. I really wasn't quietly listening. I had some airport duty last night, so I had put this on and I just gone off to sleep. I just woke up in time to see Pradnya's message. No, I heard the discussions. I think the plans that you have made perhaps is perfect. Rather than, I think, because if you're going to have a formal structure, then it becomes very official. You need to have elections and you need to have people, and it becomes too much to do.
No.
And I think that the bonhomie that you have will be lost in that.
Go away.
I think what you are suggesting is to have a sort of special, maybe one, ladies' evening or whatever during the main meetings, whenever meetings are there. Might be a good way to do it. Would be my suggestion personally. Rather than try to make another chapter association at this stage, I don't think nowhere it's there. There is another model that you could look at. Is there is a women in transplantation. There is a body again, very much like this. So the Liver Transplant Society has a group within it called Women in Transplantation. So they do much of what is being suggested. Very, very similar activities. They basically are a network. They keep in touch. They meet on the sideline of meetings. They have their own, online stuff. So maybe that's another model that you can look at if you want some structure to what it is that you are doing. It's called Women in Transplantation. There are a couple of people from here who are members. So if you need some help, then we can probably ask them to, or maybe I can get them to get in touch with you all to see how exactly they go about their activities, because they do something very similar to what you all are suggesting.
Yeah, there is
So I think, as I said, I'm honored to be the lone Y chromosome here in this meeting. So I think it's a privilege. So thank you very much, and I'm very happy. I think that this has all come together very, very nicely. I didn't see, as I said, I missed a lot of it. I hope I will be able to see it on the recordings a little later. So best wishes from my side.
Thank you, sir. Thank you.
Thank you, Sanjay. I just wanted to say one thing on these lines, that when I was talking to so many of the co-women surgeons, on the sidelines of the meetings, most of them have had a mentor amongst the male pediatric surgeons. So it's not that we feel sidelined in that way. It's just something to add on. So thank you.
And I think I can also add that I think as we see if our hospital is representative of what is going on, the demographic is changing. Today, I think at present in our department, we are there are more women than there are men amongst the trainees. And that is reflecting in many departments, cardiothoracic surgery, neurosurgery. Increasing number of women are coming up and joining these specialties. So I think there is a role for support to one another and talking. And I think the challenges you all face are unique, which we will not have any way of appreciating totally.
Thank you so much. Thank you.
Yes, Sanjay is a true he for she, right?
I like that description.
We have a body called the Women in STEM that includes not only doctors, but also scientists and teachers. And we do keep 2 or 3 male members also, because then we discuss for about women throughout the country. What should be offered to them, like they go on childcare leave, they have a break in their career. So we make out projects for them so that they are able to come back and join the field and become in the streamline again. Because many women after MBBS, if you note in your classmates must have just left out. Maybe some after surgery, some take up a different line. We have many pediatric surgeons who start doing totally cosmetic surgery or something else in different fields. I have many surgeon friends who are doing MBA and in a different field altogether. So we need to discuss this and bring people back.
Okay, thank you everyone for joining.
Thank you, Pradnya.
Yeah.
Thank you, Pradnya.
Madam, happy birthday once again.
Thank you.
And hope to see you all soon. Thank you.
Thank you, Pradnya ma'am.
Yeah.